Richard, Richard,
Good morning, ma'am.
Morning, sir.
Morning, ma'am. Please welcome for our e-CME. Yes.
Good morning, sir. I'm in a meeting with team. I've just logged in, that's all. Okay, sir.
I'm using debit card and I got 10% discount. That's 10% cashback.
Maya.
Making joke.
Hello, ma'am. Speak, ma'am.
Okay, Dr. Swatika.
Thank you.
Good.
Respected Dean, Professor Dr. K. Elilvendan, sir. Respected Medical Superintendent, Professor S. R. Rangabhashyam, sir. Respected Deputy Dean, Professor Dr. Deepthi Shastri, ma'am. Respected Director, Hospital Development Committee, Professor Dr. E.M.K. Karthikeyan, sir. VMKV NCH Sevan. Respected heads of department and faculty members of various departments, postgraduates and dear participants, a very good morning to all. On behalf of Department of Pharmacology, I take immense pleasure in welcoming you all to the e-CME on Regenerative Medicine and Stem Cell Therapy in association with Indian Stem Cell Study Group
Mani,
Association.
everyone has come? Dr. Mani?
Yes, sir.
Sir, morning, sir. Sir, morning, sir. Has everybody's joined, sir?
என்னங்க சார் ஆமா சார் என்னங்க சார் எனக்கு கேட்டு ரெஜிஸ்ட்ரேஷன் 25 சார் 24
May I now request Professor Dr. E. Manivannan, sir, Professor and Head Department of Pharmacology, to welcome the gathering.
Yeah, very good morning to all. I'm so grateful to welcome you all for this innovative e-CME on the basis of regenerative medicine and stem cell therapy. I am so grateful to each of the participants, leading pharmacologists of various colleges in participating in the webinar. We are being honored to welcome our beloved Dean, sir, Professor Dr. K. Elilvendan, who is instrumental in organizing the webinar, whose ideas in choosing the topic. We welcome the Medical Superintendent, Professor Dr. Rangabhashyam, sir, in supporting and organizing the webinar with great enthusiasm and guidance. We welcome our Deputy Dean, ma'am, Professor Dr. Deepthi Shastri, who was always motivating us for every step towards a progress of improvement and leading towards a bright future. I welcome the Director Hospital Development Committee, Dr. Karthikeyan, who is always a motivational tool for us. We welcome our beloved Professor Dr. N. Natesh Prabhu, President, Indian Medical Pharmacologists Association and Joint Secretary, Indian Stem Cell Study Group, for sharing in organizing this event. We welcome the distinguished speakers of the day, Dr. V.R. Ravi, Director, Mother Cell Regenerative Medicine, Maruti Hospital, Trichy. We are eager to listen your speeches on the speech on the basics and uses of stem cell therapy. We welcome speaker Dr. Avinash Gandhi, Chief Scientist, Mother Cell Regenerative Center, Trichy, who is going to explain in depth about the PRP and bone marrow mononuclear cell preparation techniques. We welcome all the HODs of all the departments in our Vinayaga Mission Kripananda Medical College and faculties of VMK VMCH in participating this event. We invite the ISCS GA office bearers, leading physicians, cardiologists, microbiologists, pathologists, preventive medicine specialists, beloved pharmacologists. We welcome the junior pharmacologists, postgraduate all over India in participating in this academic feast. Over to you, sir.
Thank you, sir. May I now request the Dean, Professor Dr. K. Elilvendan, sir, to address the gathering.
It's a very proud moment of Vinayaga Mission Kripananda Medical College and the Department of Pharmacology. Dr. Manivannan and the team have initiated this topic on regenerative medicine and stem cell therapy. I said is immediately we have to go ahead because the stem cell therapy is the one like it's a current, it's the one like a future, it's the one like a past. But in stem cell therapy, the current and for the future, lot of developments is happening in the stem cell therapy because of that many department is like lot of this. If you take a bone marrow, is that even this ophthalmology is happening, even whatever the tissues damages may happen, or irreparable areas, everywhere the stem cell therapy is going to happen. For that, regenerative is the word is already used for the geriatric aspects and many things. It's be very useful for orthopedicians also and for the general people. For this kind of topic, if you go for the search and the number of books around 20 and 30 and taking your points, instead of that, the great people, the great speakers, Professor Dr. Natesh Prabhu, MD Pharmacology, the President, Indian Medical Pharmacologists Association and Joint Secretary, Stem Cell Therapy. Dr. V. Ravi, I heard about his speech, a lot of things from Maruti Hospital. He's Director, Mother Cell Regenerative Medicine, and Dr. Avinash Gandhi, the Chief Scientist in the Mother Cell Regenerative Center, Trichy. So these great speakers, they're coming to Vinaya Mission Skrivananda Warrior e-platform and is going to give the big lecture to all of us, not only the postgraduate, the faculty, and all over the India, the many pharmacologists have joined. This is a great pleasure to see the topic. I told you the vast topic. They want to talk more number of books if you want to read, but they're going to just say the bulletin points to you people in a very sharp manner. So this is what the postgraduates are lucky enough. I want to congratulate all the three speakers. I want to welcome the three speakers because of Vinaya Mission Skrivananda Warrior Medical College. I request the three speakers, sir, whenever you have a free time, please do come in Vinaya Missions and do topics in the CME, or like any seminars, or we can conduct as a Tamil Nadu stem cells conference also. We are willing to do. You should participate and just you share your knowledge to our postgraduate as well as undergraduates also. So I request all three of them, Dr. Natesh Prabhu sir, Dr. V.R. Ravi sir, Dr. Avinash Gandhi sir. And it's also, I'd like to welcome, there's a Manish Karna and a Sandeep Srivatsa and a Kanchan Mishra and Madan, all the office bearers of the Pharmacology Association, Stem Cell Therapy Association, and our head of the departments, the faculties, and loving postgraduates, to all of you, it's a wonderful topic. Once again, I want to congratulate Dr. Manivannan for this this topic. It should not be only it's NCR. So always the professors and the teachers as well as entire undergraduates, it's not end speaking. Today is once finished, it is a beginning for our stem cell. It is also, we like to collaborate of all research works. So scientist sir is there, Dr. Avinash Gandhi. I request, sir, I will ask my colleague, Dr. Sendil and his team. They are very much interested in the stem cell therapy, sir. Research, kindly guide us to go for the further, sir. Thank you so much. Congratulations, Department of Pharmacology. My special congratulations to Dr. Manivannan. Thank you.
Thank you so much, sir. May I now request Professor Dr. Deepti Shastri ma'am, Deputy Dean, to felicitate the program.
Respected Dean, Medical Superintendent, Director, Hospital Development Committee, distinguished speakers, Professor and Head and faculty members of the Department of Pharmacology, and all the esteemed participants, good morning. As the Department of Pharmacology hosts this CME on regenerative medicine and stem cell therapy, I extend a warm welcome to the distinguished speakers, Dr. M. Natesh Prabhu, Dr. V.R. Ravi, and Dr. Avinash Gandhi, and to all the esteemed participants. I'm sure the insightful and engaging sessions will foster a deeper understanding of the transformative potential of these cutting-edge advancements in the field of healthcare. Wishing this CME great success and congratulating the Department of Pharmacology for organizing the CME and wishing all the speakers all the best. Thank you.
Thank you, ma'am.
On behalf of the Department of Pharmacology and VMCH, we welcome the Tamil Nadu Medical Council appoint Professor Dr. Dhanapal as an observer on behalf of TMC for this program. Please welcome, sir.
Thank you, sir. May I now request Dr. R. Ramya, Associate Professor, Department of Pharmacology, to introduce the speaker, Professor Dr. M. Natesh Prabhu, President, Indian Medical Pharmacologist Association and Joint Secretary, Indian Stem Cell Study Group Association.
A very good morning to one and all. It's my privilege to introduce our guest speaker, Dr. M. Natesh Prabhu. He is Medical Director and Men's Health Consultant for Androgen Clinic and Androgen Medical Center, Trichy. And he is Professor of Department of Pharmacology in Dhanlakshmi Srinivasan Medical College and Hospital, Perambalur, Tamil Nadu. He has done his MBBS from Pondicherry University and MD from Manipal University. He is a he has fellowship certificate in sexual medicine and advanced clinical andrology. He is the president of Indian Medical Pharmacologist Association. He is a joint secretary in Indian Stem Cell Study Group. He is regional representative of South Asian Society for Sexual Medicine. He is a director of Grid Healthcare Partners Private Limited. He is Stem Cell Ethical Committee member in AIMS, Rishikesh. Well, we welcome you, sir. Thank you for being as a guest speaker for our e-CME.
Thank you, ma'am. Now I request Dr. Natish Prabhu, sir, to deliver his speech on pharmacodynamics of regenerative medicine.
Thank you so much, sir. Thank you, Dean sir and Dr. Manivaran sir and Dr. Ramya for this kind introduction. And I welcome all the delegates. So we actually recorded the video to avoid any delays in the presentation. So I'm going to share the video. If innovation team has the video, they can share from there, or I'll be able to share from here.
Dr. Ramya.
Or else you can give me the sharing option, make me a co-host or share option, then I'll be able to share, sir. No issues. Just enable the sharing option for me. I'll be able to share.
Okay, sure.
So good morning, everyone. At the outset, I thank the organizers for inviting me to deliver this lecture on the topic of pharmacodynamics of PRP and stem cells in erectile dysfunction. Erectile dysfunction is a disorder which is characterized by the persistent or recurrent inability to achieve or to maintain an erection during sexual activity. This sexual activity could be a penetration or masturbation. ED is not just a disease. It is not just merely a bedroom problem. It is a more than a disease. It could be a sign of an undiagnosed or imminent cardiovascular event. That is why penis is considered as a men's health parameter. There could be various causes: psychogenic, hormonal, iatrogenic, drug-induced, developmental, neural, and vascular being the most common cause. And not to forget that penis is a vascular organ, and we can see a lot of cavernosal sinusoids being covered by the cavernosal smooth muscle cells. These forms a basic dispatch mechanism of accumulating the blood inside the tissues during the erection process, which is accompanied by the stoppage of the outflow by the venous the mechanisms. We should understand this erectile dysfunction beyond this arterial and venous flows. They have found out that this has been found out even decades ago. in ED, there is a presence of excessive amount of fibrous tissues and loss of smooth muscle cells. And this ED is very specifically, arterial ED is a diffuse penile disease, where they found out there is a decreased amount of smooth muscles and increased percentage of the collagen fibers. This slide shows where the cavernosal tissue changes in erectile dysfunction, which is nothing but a decrease in the muscle collagen ratio. In the management spectrum, we have basically the lifestyle modifications, treatment of comorbidities, the correction of the underlying causes, and of course the PD-5 inhibitors like sildenafil and tadalafil, and finally the regenerative therapies. So we all know how this PD-5 inhibitors act, because for an erection we need nitric oxide, and this nitric oxide levels are being maintained or being balanced by the PD-5, that is phosphodiesterase 5 enzyme. When we give this PD-5 inhibitors, this phosphodiesterase enzyme get inhibited, therefore there is increased amount of nitric oxide in the pineal tissues, which again increases the cyclic CMP and further downstream pathway leading to the cavernosal smooth erection, finally the pineal erection. So ultimately there needs to be the presence of nitric oxide. If there is an absence of nitric oxide in case of an ED, the ultimate erection is gone. When the patients don't have sufficient amount of endothelial cells which produces the nitric oxide, they are termed as PD-5 non-responders. For this group of patients, we have penile implants, we have bimix, trimix, we have multiple drugs which are again quite cumbersome, which eventually causes more and more of fibrosis. So what is needed in these patients? We need angiogenic factors, we need neurogenic factors, and we need all the factors which are yet to be discovered, which again increase the nitric oxide production. And for this, we have various regenerative therapies. And when we classify these therapies, can be a cell-based therapies or energy-based therapies. Under cell-based therapies, we have PR, there is platelet plasma or platelizate, peripheral mononuclear cells, bone marrow mononuclear cells, and the mesenchymal stem cells. And when you tell about these energy-based therapies, we have shockwave therapies, we have laser-based therapies, which I will be covering in this lecture. So the importance of VEGF has been overemphasized, and of course, VEGF is one of the most important things which is required for neoangiogenesis. So this VEGF, they act on the VEGF receptor on the cell surface of the vascular endothelial cells. This further leads to the phosphorylation of the tyrosine kinase internally, and this tyrosine kinase increases the production of the downstream pathways, increases the production of the endothelial nitric oxide synthase. This ENOS increases the nitric oxide levels, and this nitric oxide they diffuse into the cell, therefore causing vasodilation. This ultimately can be given by the platelet plasma, which is nothing but the plasma which has been enriched with the growth factors, which are released from the platelet granules and which are necessary for the tissue repair and regeneration. And these granules, that is the alpha granules, or the storage factories inside the platelets, which store all those necessary growth factors. And these alpha granules of the platelets, they have been called as angionurin. That is, VEGF is called as angionurin because it is also responsible for both neurogenesis and angiogenesis. Apart from all the other factors, and this VEGF has been more emphasized. So the rationale of giving PRP is to stimulate the natural healing cascade and tissue regeneration by a physiological release of platelet-derived factors at the site of treatment. And we require this PRP activation to release those stored factors, those stored growth factors in the alpha granules. And as far as we found out, the most effective way of causing the activity is either it can lyophilize, or it can do the freeze thawing, or it can combine the both. And of course, PRP have various factors, there's PDGF, TGF, IGF, VGF, and the basic FGF, which have basically to increase the smooth muscles proliferation, integrity, angiogenesis. Therefore, there is the regeneration of the cavernosal tissues. The PRP by these factors, that is VGF, PDGF, IGF, FGF, they increase the proliferation and diffusion of the MSCs. They restore the smooth muscle integrity causes neurogenesis. They also increase the ECM and the collagen synthesis. Thereby, they restore the erectile function. So this is the main pharmacodynamics behind the PRP. Now, coming to the stem cells, we have various stem cells sourcing from the umbilical cord, the water jelly, the bone marrow, the adrenal pulp, and the adipose tissue. So, why do we choose these MSCs? Because these MSCs are immunoprivileged. That is, they don't require matching. They can be given for unmatched patients. And they also have an immunomodulatory activity. And these MSCs can be extracted easily from the adipose tissues, bone marrow, dental pulp, and the peripheral blood cells. And the main mechanism of action of stem cells is based on the homing. That means when there's a signal, when there is a the cry of the dying cell, these stem cells, they migrate. This is called as homing. Once they migrate, they convert themselves into the cell which is required for the or which is being asked for help. This is called as trans-differentiation or called as plasticity. The second being the paracrine effect. That is, it goes there, it stays there, it understands the cellular milieu, and it stops to secrete the cytokines and growth factor, which are responsible for the tissue repair and regeneration. And most important, or recently found out, the mechanism is cell fusion. They go there, they fuse with the damaged or injured cell, and they exchange organelles, very specifically mitochondria. It's called as organelle transfer. So with these three mechanisms, transdifferentiation, the paracrine effect, and cellular fusion, the MSCs act on the injured or the repaired or the fibrous cells. So this slide shows the pharmacodynamics of the mesenchymal stem cells, where they release the angiogenic factors, where they release neurogenic factors, and they cause the upregulation of the nitric oxide synthase pathway, thereby causing the reduction in fibrosis and smooth muscle regulation. They also increase the CXCR4 signaling, therefore causing the mobilization, proliferation, and differentiation of stem cells. This all causes angiogenesis and nerve fiber degeneration, which again improves the erectile function. So there are multiple articles, and I'm just showing one of the articles which been recently published, and where they have segregated ED due to diabetes, hypercholesterolemia, or hypertension, or all those three, and they found out that that's a significant increase in the penile Doppler values. And we are doing a research on PRP. That is all PRP in erectile dysfunction. This is a meta-analysis, and we have taken many articles, and this is being going to be presented in the recent upcoming sexual conference in Madrid. So this picture. This is how we inject these PRP or stem cells. This is by giving the intracavernous injections. This is over the patient will be slightly anesthetized by giving intravenous sedation, because we have to give a pain-free, very comfortable thing for patient, because many clinicians, they prefer local anesthesia, but we prefer this GA. This is injection of a PRP for the patient, but basically it is an intracavernous injection where the extrusion site has been cleaned up, and to avoid the injury for the urethra, we choose either the 3 o'clock or the 9 o'clock side or the penis. This is a freeze-flow activated PRP being given for patient with vascular ED. So both sides, this PRP is being injected. The patient will have immediate effect, and he'll be having a long-term effect. And these injections are not one-stop solution. They have to be repeated. They have repeated at necessary intervals, and even boost doses has to be given, because the regenerative capacity has to be assessed before giving these treatment sessions for patients. So therefore, I'm concluding by saying that regenerative medicine is a cellular pharmacology, and it is a present and not the future. In a conventional pharmacology, we do a substitution and symptomatic therapy, but in cellular pharmacology, we regenerate and reverse the disease process. I want to pay always tribute to my teacher, late Professor Dr. Shankaran sir. And thank you. And if any questions, you can always email me. Thank you for the opportunity once again.
Thank you for
Can
your
I ask a question? Can I ask a question?
Hello, sir. Please tell me, sir. Morning.
Hello, very nice presentation, Natesh.
Thank you. Thank you.
Congratulations for conducting such a very wonderful session on stem cell therapy. It was right time, and it was required by all of us. Yeah, my question to you is, do you add calcium chloride or any calcium reagent along with the platelet with plasma when you inject into the penis?
Sir, the issue with the calcium chloride is that, so once you put the calcium chloride, it's called as a release rate.
Yeah.
We can never measure the intensity of the releasing patterns.
Okay.
What the device actually measures is the baseline platelet.
Yeah.
It is called the device efficacy up to the centrifugation.
Yes.
By adding the calcium chloride, there is a pharmacokinetics for the patient of the factors being released. So they have found out that this is quite beneficial for other diseases, for ulcers, for dermatology. But when it comes to the ED, this autologous platelet activation has a humongous variability. So with the experience, what we found out is it is better to go for lysate, not releasate. The advantage of lysate is that in releasate, we'll be having only growth factors from the alpha granules. Whereas in the lysate, we'll be having the factors which are present on the membrane, as MMPs, and few other things also, because we will never know, because they have found out that only by giving VEGF, the efficacy is not achieved at all. So there is an interaction of the factors. For example, VEGF, it interacts with angiopoietin-2. So I can say more about that. But still, for the question asked by you, we can avoid this calcium chloride because it is once in case of ED, because we did our own meta-analysis where we found out that there is a good efficacy, but huge variability. The I-square value is huge variability. And nowadays, we are moving towards PRP standardization. That is dose-specific PRP. We are still framing that. And as of now, people go for freeze thawing, and they can go for 3-cycle freeze thawing. They can achieve a maximal platelet concentration, and they can go for an optimal 3-cycle freeze thawing. It is called as you either freeze in a refrigerator, that is cold refrigerator, or you can dip it in a liquid nitrogen, and for a couple of minutes, and thaw it in room temperature for 10 minutes, and again repeat the cycle for 3 times. So they have found out that maximum you can do for 5 times, but 3 times are being optimal, because every time you do freeze thawing, there are differential release of growth factors. As we are focusing on VEGF more, they have many research, and at least few research articles have concluded that 3 cycles of freeze thawing is enough to achieve a optimal VEGF activity, because beyond this 3 cycles of activation, VEGF levels are not being increased. TGF beta levels reaches plateau by the 5th cycle, whereas VEGF activation, the levels it's getting activated by, it's getting in the plateau by the 3rd cycle. It is quite easy enough.
Yeah. Can you please permit me to ask one more question?
Please, sir.
Yeah. How much platelet, how much plasma you inject per session? How many ml of blood you draw and how many ml of plasma you inject?
So it is advisable to take around 30 to 40 maximum. 30 cc is quite an average. You take it and you make sure there is a baseline platelet value of 1 lakh per ml. Of the
You
PRP
mean to say
of the PRP which you prepare. And they say to keep a maximum of 1.5 to 2 ml of the plasma. But here we prepare the PRP and we lyse it. So there is no concept of how much ml of plasma is required. We maintain the baseline platelet level. You make 2 ml of plasma so that the platelet can lyse. and whole thing
Ah,
can be dissolved and you can give in the appearance immediately.
I didn't understand. Can you please explain? Once you centrifuge, out
So
of
once you
32 ml
centrifuge, then there will
blood, you
be
will
a,
get about 12 to 14 ml of plasma. In
yeah, in
that,
the,
that blood, yeah,
yes, sir. Please.
please go ahead.
Yeah, so once you centrifuge, what happens? See, for people to understand, I'm going to divide this PRP into 3 segments. One is you have your own tubes. That is, you
Yeah.
have your own Falcon tubes. You know how to prepare PRP. So
Yeah.
you take a gamma irradiated Falcon tubes
Right.
and you withdraw the 30 cc of blood in the ACD. That is, you have
Yeah.
anticoagulant. Okay, ACD is there. You can add 1.5 to 2 ml of ACD to withdraw that, and you mix in a different level, different Falcon tubes. You can split it up because you know that.
Yeah.
Then you centrifuge it. I would prefer people to centrifuge in a swing out bucket, not in
Okay.
fixed rotor, because once you do in a fixed rotor, what you get the sediments and the plasma. It is like it is a conical way. So
Yes.
once you do the swing bottle type, where once during the centrifuge, the centrifuge tubes, it goes like this. It becomes perpendicular to the centrifuge.
Yes.
So by doing this way, you'll be getting a good amount of plasma, platelet,
Yeah.
and RBCs.
Yes.
In the second spin, you're going to concentrate more of a plasma, platelet, Buffy coat, and the RBC. Sorry,
Yes.
plasma, Buffy coat, platelet, and the RBC.
Yeah.
Now, in the first spin itself, we will be discarding RBCs. In
Yeah.
the second spin, you might get very minimal amount of RBCs, very minuscule. So it all depends upon how we're going to sanitize your centrifugation protocols. I don't want to discuss here because we calculate by doing RCF, relative centrifugal force, and give the number of G forces. Because once you do that, depending upon the diameter of the rotor, then you can you can convert the RPM. This is a lab sanitization. So in depth, I'm not going to go into that but people can know about this.
Yeah.
So regarding this aspiration, once you have this platelet core plasma in the upper segment, and the small amount of platelet be there, around 1.5 to 2 ml, it is sufficient along with the Buffy code. Because this Buffy code is WBCs. We require leukocyte rich PRP.
Right.
Because that is we have seen there are 2 types of regeneration. Initial 1 to 3 or 1 to 3 I can keep. It's this regeneration, we have seen there is an inflammation where immediately after injection, the penis, people can have a transient increase in size of the penis. Both in the girth and the length. People will be so happy about that. But as days progress, 16 weeks will be the maximum time of reach because it's all the article says 16 weeks. We have seen, we observed in around 8 to 12 weeks.
Okay.
People witness actually girth and size. But this is not to be extrapolated to the penis increase in size because there's a regeneration because there is increased amount of arterial, the cavernous sinusoids. So once you give this way, that is the 1.5 to 2 ml of the plasma, this near the platelet, along with the Buffy code, this is sufficient. But our recommendation is towards the platelet lysate. You take it, you lyse it, then you give it. A second concept of the PRP is called as PRP centrifugation tubes, which are available in the market. One such tube is something called as vortex-based centrifuge, where you can see, I'm not going to mention the brand here because it will be a promotion-based thing, but there are quite certain brands where it is a closed system, where you have to inject the blood. Spin itself, it is going to maximally concentrate the platelet and the RBC and the plasma. Sometimes you require 2 spins, but the machine itself will be spinning that.
Okay.
More commonly, what is available is a gel-based centrifuge, which I would say it is not quite acting good for the ED. Why? Because in the gel-based centrifuge, again they have 2 segregations. One is PRP and PRGF. In PRP, they don't have the activator. In PRGS, PRGF or GCF, this is called as growth factor concentrate or plasma-rich growth factors. They add calcium chloride in there. So in that, once you do a first centrifugation, sometimes they'll tell only one is enough. The gel act as a differential gradient. So below the gel, there'll be RBCs. Above the gel, there'll be a platelet, buffy-gold, and the plasma. So it is easy for them to activate, to aspirate. In the calcium chloride bound tubes, you get what only is a plasma rich in growth factors. So these three things are there. My suggestion again, the vortex-based centrifuge, at least it is closed, it is sterile. And the gel-based centrifuge, again, it is gamma irradiated. Both would have got approval of the CDSU or the CGA to market it for the use of PRP. There is no indication specific usage, but you can sanitize this PRP in your lab. There is no fixed kind of how much of PRP is required. Why? Because for hair regeneration, for skin and all, they require more amount of plasma. They require more PRP. So they want to inject in a multiple area. For us, 1.2 to 1.5 to 2 ml of plasma is more required, sir. So this is so I have divided into 3. So with your own certification, you can use 1.5 to 2 ml.
So as far as you are concerned, what you are going to do with the rest of the plasma, superficial plasma, which is only purely plasma?
Yeah,
you are going to discard it?
People inject it, but there is no range because
no.
If you are not,
what about you? No, I'm asking. What about you?
Yes, I'm telling. That is what people inject it because they put calcium chloride in that.
Yes.
We are not putting calcium chloride, so we discard it.
Okay. What about the RBCs?
Yeah, we discard it.
We don't. You don't use it as filler for the skin, subdermal filler.
True, but again, this discussion on DED, but people are that.
Okay. No. Just ask whether you are discarding it or reusing.
No, sir, we are not doing this.
Yeah. And what about injecting for the 2 spots? So why can't you inject only to 1 spot? Because intercommunicating vessels are there. Both these sponges are interconnected. Even when you inject, it will go to the other side also.
You would
and last question, I will not take much of your time. Do you use any vasodilator injection, that is PG1 or papaverine or any other thing along with plasma or along with PRP?
Good question, sir. So the first question you said is why 2 sides, why not 1 side?
Yeah.
If you observed while injecting this ICI VAD, heparin or like whichever alpocidil, while watching the USG and all, you would see that diffusion happens, but not in a uniform way.
Yes.
It goes like that, many stays like that. So what we want there is an arterial dilation.
Okay.
But in case of PRP, we want all the sinusoids to absorb the PRP and not being drained outside. That is why we want to maintain low amount of plasma and we want to lyse it.
Okay. So I really appreciate that.
We don't need PG1, sir. We don't, because once you give PG1, there's a high chance it'll go for a venous drainage.
Yeah, I highly appreciate your rationale behind the use, because there are 2-3 schools of thought to inject the entire plasma, to inject along with PG1, alpostidil or papaverine, so that there will be vasodilatation, and use vacuum pump before giving the PRP, so that spongios are expanded, so that it will be easier to inject into the spongiosa. Because if there is minor fibrosis, if you do vacuum pumping before injecting, the spongiosa would have expanded and it will be easier for us to inject. So many things are there. So thank you very much, Prabhu. It was an excellent
I want to add one thing there. Thank you, sir. Yeah. So while using these pumps, what is happening? You are opening up the venous channels.
Yes.
And we would ask the patient to withhold either tadalafil or sildenafil a day prior to the procedure. One is the fear of hematoma. And second is, again, we don't want erection to happen during the injection.
Okay.
So we want the periods to be as small as possible, so we can expand by pulling it and we inject it. Sometimes we have initially injected only in the base, but now we are following the protocol. One is we divide 0.5 into 3 segments: 0.5 in the base, 0.5 in the mid shaft, and 0.5 just distal to the coronal sulcus on the both sides. So we're going to spread the injection, so the regeneration is maximal. Still, we don't take care of the proximal cavernosa. We just inject in the distal cavernous. Hope you understand that. Which is in
Oh,
the
yeah.
epigramus here.
Yeah.
And
Yeah.
sir, you are a senior. I'm very happy
No,
you
but in
joined us.
fact, I was the one who started PRP way back in 2016.
Understood.
If you
Aware
go
of
back
that.
to the history of PRP, I presented this paper in Singapore and I won the best research award for that year because I was the one who introduced PRP to the penis first time, 2016. Later on, so many people have contributed. Of course, it has grown beyond anybody's control.
We are aware of that,
So
sir.
that's why I just asked these questions.
Thanks for joining, sir. Thank you.
Yeah, thank you. Thank you so much. Very informative. Yeah.
Thank you.
Please carry on with other questions.
Thank you, sir. Any other questions from the audience, sir?
Excuse me, can I ask one question? I'm Dr. Sita Lakshmi.
I have a question.
Dr. Siddharth, madam.
Yes.
What is the role of regenerative medicine in anemia treatment, sir? Is anything available like that?
Sir, to my knowledge, anemia is due to RBCs. Correct. So, to my knowledge, that is, we have not found any role for anemia, sir. If you know anything is there, then I will let you know. Madam, please go ahead.
Yeah. Good morning. It was an excellent presentation and we got so much of information. And thank you, Sharath Kumar sir, also for pitching in, and that discussion really helped a lot. And sir, Dr. Natesh, I would like to ask you a question. How frequently do you inject and what is the cost factor involved for the patient?
Okay. So the frequency of injection, again, you are asking about dosing. Dosing, we are standardizing it. Recently, in June, I was invited to form a guidance document where there was discrepancy in the guidance. So we went back and we are still framing up something called dosing. How frequent should we? Moreover, you should ask how much we inject. That means what is the dosage of each factors to inject. So we are standardizing it. There are many protocols, there are many articles, and International Society of Sexual Medicine.
Open label expensive. Open label அந்த படத்துக்கு எக்ஸ்பென்சிவா இருந்துச்சு சார். அந்த படம் எக்ஸ்பென்சிவா இருந்துச்சு.
Mute the audience, please.
Open label actually ஒரு டிக்கெட் எக்ஸ்பென்சிவ் சார். எல்லா இடத்துலயும் அங்க மட்டும் இல்ல. IMAX experience recommend பண்ணேன் டைரக்டர்.
Can you mute the audience?
Expensive ஆ இருந்துச்சு. அதோட தான் இருக்கிறது எக்ஸ்பென்சிவ். ஓகே சார்.
Dr. Ramya. Okay. So regarding the dosing, yeah. So regarding the dosing, we had to frame the guidelines, madam. So we as of now, like, so it is experimental. There is no one question for that. What we can ask is that as of now, for a researcher, there are many ways to prognosticate the response. Yeah. So we have few modalities to prognosticate. The basic thing is called as the penile grayscale ultrasonography, where you see the echogenic focus. This has to be done with a dedicated sonologist. Why? Because many times radiologists they see only PSV and EDV and the RI, which is one way is good. They want to say that when the PSV is low and when the EDV is high, there is venous leak. But I would like to say that when there is a cavernous fibrosis, this high EDV is due to the CVOD, cavernous occlusive disease, because it is preventing the expansion of the arteries. So by using the grayscale, there are articles showing that pathognomonic echogenic focus in case of diabetic ED, priapism ED, ED due to atherosclerosis, and few more. If you have a better center, you can go for shear wave elastography. It's a probe which is going to.
I didn't get you.
Shear wave is it's an ultrasound technique. It's an imaging technique where they have a very specific probe. They measure the transverse and the longitudinal segment of the penis. They put a pressure in the very specific area. They see how stiff is the tissue.
Okay.
Stiffness, increased fibrosis. That means what? There is an alteration in the muscle collagen ratio. There is increased collagen, which is it has lost its wavy form. If you can see the PAT pictures, this way you can do that. And most And the most we can say gold standard, which is not being done now, which is pineal biopsy, but we can't do regularly. So once there is a pineal biopsy done, we can see how much exactly is the damage, and so there can be sealed studies also, but which is quite not possible due to the infection, hematoma. But again, they have done research showing that it is completely safe. So as of now, what you can do for frequent determination, you should gaze ultrasonography, see how much it is improving. Okay, as of now, there is not even a fixed standardization of the PRP preparation. So we can't tell how frequent you can inject also. That's the problem.
Interval, as of now, minimum interval.
Yeah, so 16 weeks we can give. Then we can always say 3 to 4 months you can give.
That is once in 16 weeks.
Yeah, because RTL says it takes 16 weeks for new angiogenesis. See, I'm telling, but these ways you may lose the patient. So you have to personalize that, and you have to combine. You have to have a multimodal approach: shockwave therapy, PRP therapy, and lifestyle modification, smoking cessation. People go for PRP for non-consummation, which again how complicated it is. I won't tell you because we're expert in that. And still, for assessment, we need these things, and for non-consummation, it's better to avoid that. I want to emphasize here.
Factor, cost factor.
The kit comes at a cost of ranging from 3,500 to 18,000 rupees. So it all varies. And if you're going to prepare your own PRP in the lab, so it's up to you.
Thank you so much.
Yeah, can I contribute something, Dr. Sita Lakshmi? Yeah, usually we do give the PRP monthly ones for 5 to 6 sittings. Monthly ones for 5 to 6 sittings, because the platelets ones which is injected into the penis, for the growth factor VGF and others to go and work inside the penis, it requires 3 to 4 weeks. So we give a time of about, say, 30 days for the injected PRP to work over the penis. That is for regeneration of the tissues inside. Like that, we repeat it every month up to 5 to 6 months. Minimum 3 months is required to get the result. With only one PRP, one may not get good results. With 3 PRPs, one starts seeing the results, and 5 to 6 sittings are required to get the best result.
Thank you so much, sir.
Yeah, welcome.
A small addition to this discussion, because being pharmacologist here, somebody has to do a trial in this PRP.
Please.
Yeah, when Sir said results means it is about IAF, assessing the International Index of Erectile Function Score, or the SIM score, abbreviation of that. And what you can visually see is dose de-escalation study. You give tadalafil, you see how much is responding, and with the case of regenerative medicine, you should be able to reduce the dose of tadalafil in a period of 1 month, 3 months, and 6 months. Because many times once you keep only IAF as an endpoint, patient might not get an MCI. That is minimally clinically important difference. But when you keep a dose escalation study, your perspective of assessment is different. So you may see a very significant change also. So any more question I can take, or you can go to the next session of Dr. Ravi.
Any other question from the audience? Thank you for the valuable session, sir. Thank you once again.
Thank you. Dr. Ravi is there, and you can unmute him also in case, but after playing the video. Ravi sir, good morning, sir. Sir, you are muted, sir.
Yeah, good morning. You can play the video.
Yeah.
Now I would like to welcome Dr. Swatika to introduce the next guest speaker.
Now I am here to introduce the speaker, Dr. V.R. Ravi, orthopedic surgeon, Director of Mother's Regenerative Center. Sir graduated MBBS and Diploma in Orthopedics from Tanjore Medical College and MS from Madras Medical College. And he was working for the past 24 years treating various polytrauma cases. And for the past 10 years, his team has evolved multiple modalities of regenerative medicine using peripheral blood. Past, he was working as a junior orthopedic consultant in Seashore Hospital and senior orthopedic consultant in Coventry Medical Hospital. Currently, he was working as a senior orthopedic consultant in Morathi Hospital, Trichy. Sir also a specialist in orthopedic and trauma surgery, joint replacement and spinal injuries, regenerative sports medicine, stem cell researcher, plasma products innovation and patent holder, tissue engineering of bone and cartilage. I kindly welcome you, sir, to give a speech on DCGI approved stem cell therapies. Over to you, sir.
Organizers for giving me this opportunity. So this talk will be about the FDA approved orthobiologics. It is the Indian FDA or the Indian DCGI approved orthobiologics. Many people still don't realize that stem cell therapy is approved in India. They still think it is in a form of research, but it is already clinically approved. And when we say that is about orthobiologics, it is actually the regenerative medicine products which are derived from body's own cells as well as the growth factors which can reverse and regenerate multiple pathologies. Mostly we do it for the musculoskeletal pathologies, but it is also applicable to all tissues in the body, and it can be done either alone or in combination with surgical procedures. So going straight to the products, so India is the only country in the world which has got so many products which are approved, particularly in stem cell therapy, mesenchymal stem cells. There are 7 approved products, and the first approval started in 2014. So the ophthalmologists were the first to use the limbal stem cells. So the limbal stem cells were available since 2014, autologous. Patients' own cornea, they took the limbal stem cells and applied it for corneal blindness through the company called Reliance Life Sciences. So this was available since 2014. Similarly, now the allogenic bone marrow derived stem cells are approved for Buerger's disease, though it is available since 2021. It was approved in 2017. And since then, the diabetic ulcers, non-healing ulcers, osteoarthritis, and other indications like for skin regeneration, hair regeneration, and under-eye dark circles, the conditioned medium derived from allogenic bone marrow stem cells are available in the market. So apart from that, there are a couple of gene therapy products as well as the immune products, but our focus is on the stem cell products, mesenchymal stem cells. So this is another company, Regrow Biosciences, which has got 3 products: Osgrow, Cartigrow, Urigrow. Osgrow is for bone, where you take a biopsy of the bone, send it to the company, they will culture it and send it back to you within 3 weeks, around 50 million cells. Similarly, for the cartilage, in cartilage regeneration, and for the mucosal regeneration of the urethra, less than 4 centimeters strictures, you can take the biopsy from the mouth, from the buccal mucosa, send it to them, and they will culture and give it back within 3 weeks, which can be injected for stricture urethra. So these are some of the products which are available not only in orthopedics but also in other specialties. So this is the approval letter. You can see the date of approval 2017, 2020, 2022 for the TAO, CLIPAD, and osteoarthritis. So now any orthopedic surgeon in India can prescribe these stem cells, get it in their clinic, and use it for their patients for a particular indication. Worldwide also there are other stem cell therapies which are approved in Japan for Crohn's disease, GVHD, and for the first time for Parkinsonism, a neurological disease. They have got approval 5 doses, intravenous and intrathecal, and the approval came in 2023. Europe and South Korea also have got 2 products, but it is India which has got 7 products. So this is the product for osteoarthritis called Stem 1. So this vial contains 25 million allogenic bone marrow derived mesenchymal stem cells. So the company has done all the animal trial as well as the human trial, and then come out with a product after phase 3 trial for grade 2 and grade 3 osteoarthritis. And there is at least 1 year pain and stiffness reduction, and the cartilage quality is maintained. Volume is maintained for 1 year, whereas in untreated there is a decrease in cartilage volume with minimal side effects, and the 2-year data is also awaited. But we have been using it for autologous for our patients for more than 10 years. So this product STEM1 is obtained from 3 people, from 3 young adults taken from the bone marrow, and you can make it into 1 million doses, and it can be used for osteoarthritis, which already the approval has come, and other indications. These are pending. Next year probably we will get these approvals. So osteoarthritis, as I said, we have been doing autologous. So this is our very early case where you can see we used autologous patients' own bone marrow concentrate and injected, and within 7 months you can see an increase in the cartilage height, and that is possible only in age group of 55 to 60 years. So another case you can see another 54 years old female where the cartilage not only increase in the cartilage volume but also the quality of the subchondral bone as well as the articular margin. Osteophytes disappear as well as the articular margin becomes clear. So how long the effect lasts? So you can see that if the patient reduces the body weight, if the patient is doing all the exercises properly, not putting on more weight, you can see up to 48 months, up to 4 years, the cartilage, initially there's an increase in the cartilage volume, and as the patient walks for the next 4 years, again comes back to the same stage. So for 4 to 5 years, you can have a sustained relief of pain, and probably after 4 years, 5 years, we may have to do a booster dose. And still many people don't realize that cartilage can be regenerated, and there can be an increase in the cartilage volume, which is shown by MRI. This is from another group which has done adipose derived stem cells, and they have demonstrated the increase in the cartilage thickness in an MRI. It's not only the thickness, you can also see here also there is an increase in the cartilage thickness, but it's not only the thickness, but it is also the quality of either the cartilage or the cruciate ligament or the meniscus, whichever is injured inside the knee joint. So here is a histogram. So this in MRI you have gotten artificial intelligence software which can show that the increase in the quality of the cartilage by comparing the injured one and the healed one. If there is a shift to the left, then the quality of the soft tissue is much better. Here also you can see a partial injury healing well, and then there is a shift to the left, and this shows that the collagen quality has improved and the healing is better, scarring is much less. So this is again for a meniscus where they have with autologous PRP, they have shown pre and post injection the meniscus has healed within 6 months. So the orthobiologics, whether it is the platelet rich plasma or the bone marrow derived stem cells or fat derived stem cells, in some cases they are able to regenerate the musculoskeletal tissues like bone, muscle, tendon, cartilage, and that is why orthopedicians, dermatologists, sports physicians, and plastic surgeon diabetologists, they are avoiding amputation. They are recreating the collagen, this collateral circulation in cases of diabetic ulcer. Similarly, gynecologists for infertility and ophthalmology. So these are the people who have already started using orthobiologics. So thank you. So with the help of the other specialists also, we will be making more strides and bringing this revolution of regenerative medicine applicable to all of our patients, irrespective of their specialties. Thank you.
Can you permit me to ask one question?
Yes, you can ask the question, sir.
Ravi, sir,
Yeah.
you can switch on the video.
Hello. Can I ask a question?
So just a minute, sir. Maybe he's not. I'll call him, please.
Oh, sure.
Yeah, he's on. He's on.
Yes, you can.
Yeah. Has the bone marrow been used for the penile regeneration anywhere? Do you have any knowledge or you have used?
We have not done that. We are actually
Oh.
planning to do it.
Yeah, please do. Because
Where?
we don't have enough guts to take bone marrow and inject into the penis. Because we are worried that the penis itself will become a bone.
No. Actually, where PRP fails, bone marrow will work. So bone marrow has 6 times more growth factors than PRP. So where severe cases where PRP fails, bone marrow will work. That's a theory. So we will try to prove that. We will try to prove that.
Please.
Sir, for a question, I just want to add, as Ravi sir told, it is theoretical. You can go for a research where there are closed system. It is completely sterile. Closed system for preparing the bone marrow mononuclear cells. Because once the orthopedic surgeon takes 60 ml of BMAC, that is bone marrow aspiration concentrate, you can put into the closed system. It will be giving you the bone marrow mononuclear cells. And as I said, where PRP fails or you can expect PRP to fail, that means what? When the patient is not even responding to tadalafil highest dosages, which more commonly happens in case of diabetic ED. So you can form a research protocol, you can administer it. So depending upon how many injections and because now they come out with even for ONE, these many ml of mononuclear cells is required for a cartilage regeneration. So many things are coming up, and so it's a good scope for the researchers here, especially pharmacologists. You can coordinate with the with diabetologists and neurologists. You can form a good protocol. There are multiple closed system centrifuges available. It's called as closed system centrifuge, where you inject, where the whole thing is kept inside the system. The whole cell is maintained, and it is all approved. The whole centrifuge approved. Only you have to get the approval for a protocol from the local disease committee. That's it.
Thank you, sir. Any other questions?
Sir, I have a question.
This question is for me or for Ravi, sir?
Sir, for Ravi, sir.
Okay.
Sir, as far as stem cell preparations are concerned, are the peripheral blood stem cells equally efficacious as the bone marrow derived and or mesenchymal stem cells, sir? Because it seems like it would be operationally easier to get peripheral blood stem cells than the bone marrow aspirate or mesenchymal.
Peripheral has one more hematopoietic. So best is bone marrow.
Yes, sir.
Next is peripheral blood.
Oh, okay, sir. Sir, is there any personal experience with stem cells for AGA, androgenic alopecia?
Where dermatologists are doing.
Nice.
We will ask a dermatologist to talk at a later.
Yes, sir. Thank you.
So I think sir is driving. We would reserve the questions in the end once he reaches.
Thank you for the wonderful session, sir. Thank you, sir. May I now request Dr. G. Karthikeyan, Assistant Professor, Department of Pharmacology, to introduce the speaker, Dr. Avinash Gandhi, Chief Scientist, Mother Cell Regenerative Center, Trichy.
Good afternoon. It is my great pleasure and honor to introduce today's guest speaker, Dr. Avinash Gandhi. He is Scientific Coordinator in Mother Cell Regenerative Center in Trichy. He did his BSc and MSc from Madurai Kamaraj University and a PhD from Bharathidasan University. He has developed a patent-pending human-derived form composition for healing of ulcer in diabetic part, which we have been awarded with DPT Big grant. Welcome, sir. Kindly take over the session.
Thank you, sir. I request Professor Dr. Avinash Gandhi for presenting the topic on PRP, bone marrow mononuclear cells preparation technique. Over to you, sir.
Yeah, Dr. Avinash, he is in the he's giving a lecture, a guest lecture in different event, but he'll be joining for the Q&A. You can present his video now. He was there in the inauguration session, but now same time he is having another lecture. So please bear with this, and he'll be joining for the Q&A. You can play his video.
Everyone, this is Dr. Avinash, and today we'll be discussing about the preparation of platelet-rich plasma. As this becomes the basic of regenerative medicine, we'll be dealing on the same preparation, various methodology of activation, and further application of the same. Before dealing with the platelet-rich plasma, that is PRP, we need to know about the components of blood, that is 55% of which is plasma and 45% of which is RBC, WBC and platelets. PRP is a composition of concentrated platelet in the plasma component. Most of the function of PRP comes in as a hemostasis as well as in tissue healing. And this is separated from the blood based upon the specific gravity of the cells. Yeah, here we have is one of the publications on the application of PRP in TM joint pain. You just focus about the treatment modalities. It's a PubMed index journal. This is another journal focusing on same PRP application on the TM joint pain. I just want you to focus on one point. I'm just comparing two slides, two publications together. When you just focus on the preparation of PRP, when you just note about the coloration of the PRP, both have reported different results in their publications. One is working and one is not working. So the parameter here is the quality of PRP which is prepared is not being nice, so that the result was also not that much good. So this is what I'm here to talk about, how much you are going to work on the quality of PRP during preparation so that we can have good results on the patients. So in this talk, we will be covering about the definition of PRP, content of PRP, types of preparation, methods, various methods of activation, certain uniqueness about the PRP preparation, and the concepts which we know and which we don't know about PRP will be dealt. As from 1986, we have seen that based upon the platelet number, there are various reports which states that PRP is being standardized based upon the platelet number, amount of growth factors present in it, or total volume of concentration, how many folds it is being done. And finally, we have just landed up with the minimal acceptance that when a PRP is prepared, the platelet count must be 3 to 5 times 5 folds increase must be there, and minimum of 3 million platelets per microliter has to be there, so that it can work as a medical grade PRP can be having a minimum of 1 to 3 million platelets per microliter. So this is what is current standard. So we must have the practice of counting the platelets before and after preparation. So when what will be your fold of increase, that has to be at least standardized to proceed further. But this is also not going to help you when we just deal the same. So platelet rich plasma has to be 3 to 8 times, the platelet count has to be 3 to 8 times higher, and a minimum of 1 million per ml has to be maintained. And based upon the amount of platelet and amount of WBCs present in that, platelets can be of the further types. One is pure platelet rich plasma, which is devoid of leukocytes. So whenever a regenerative protocol, when there is no need of any leukocyte, we choose this kind of PRP, pure platelet rich plasma, and leukocyte PRP, that is LPRP, and pure platelet rich fibrin, and leukocyte and platelet rich fibrin mixed composition. So each and every type of PRP finds its application on its own depending upon the type of defect or degeneration that the patient is going to be facing. So this is a schematic representation where PRP can be autologous, allogenic, or Buffy-coat based or plasma based. Buffy-coat is going to have WBCs, and plasma based is devoid of WBCs. And either it is activated outside the body or it is non-activated, or if it is given in soft tissue, then activation happens after injection. And depending upon the application, PRP can either be used as alone, or it can be coupled with some scaffold, or it can be used with stem cells or other cell-based protocols also. So whom to choose? Now I have just stated you various varieties of PRP, but there is one more high grade form of PRP which is available in the market, that is platelet derived growth factors, PRGF. Platelet release growth factors is available, which is another form of PRP, but we don't prefer that because in case of PRP, we'll be using only this area, that is half of the plasma where the platelet amount will be more. That is what is considered as PRP. But in case of PRGF, the tube itself will have an activation component where the tube, after collection of blood, we need to incubate it for a longer duration. That is 30 minutes minimum for the activation to happen. So once it gets activated, then the release of growth factor will be there in the entire plasma. So we need to use the entire plasma for the in order to have that growth factors in it. So that is where the difference between PRP as well as PRGF. So depending upon your application, we need to choose it in a proper way. And there are certain other factors such as ACS, that is autologous conditioned serum, or the Goldick method of PRP, where we will be having glass beads coated with chromium sulfate, so that this external compound, the main point on this ACS is blood is collected without ACD. So it is this only serum. The syringes are capped and incubated with glass beads coated with chromium sulfate for 37 degrees for 24 hours, and then it is filtered and then being used for any indications. And another kind of protein source is autologous protein solution, where cytokines are made to produce by from the platelets, and it also has pro as well as anti-inflammatory factors. So there is another parameter to be considered for before application. So now we have seen the types of PRP or something that is being similar to PRP, but initially we must be doing only one basic thing, is understand what is platelet rich plasma and how it is being prepared, and then we can switch on to any upgrades or any side derivatives of the same. So basically the main two steps are double spin method, which is being approved by the FDA. So it's soft spin first and then hard spin, and the activation can be done with the help of calcium chloride, thrombin, or mechanical means, or collagen. Collagen is a natural source of activation in soft tissues, but that quantity of collagen present at the soft tissue will not be sufficient, so final activation is always needed. So during the zymogenic phase, the alpha granules stay intact, and once the activators are being used, not only from alpha granules, but the lysosomes as well as the core dense granules starts to produce certain factors, and these are the factors produced by the various granules, dense granule, alpha granules, and lysosomal granules, of which in case of regenerative medicine, we will be focusing on the alpha granule components, which will be having the growth factors such as EGF, endothelial growth factor, which regulates cell proliferation, survival, insulin-like growth factor, key regulator for cell metabolism, and PDGF is a platelet-derived growth factor for connective tissue and certain other cell types, mitogenic effects, and what we left, VEGF, vascular endothelial growth factors. So this is the normal methodology of collection of venous blood, and then it is being centrifuged and then used for any other application. The one thing which we need to focus is, did you just notice about this centrifuge? This we will be dealing it in next few slides. One thing is the RPM. So First thing is that rotation per minute has to be set, because most of the publications will be having different levels of spinning methodologies. One is one will be stating 2000 rpm, others will be stating that 3000 rpm. So that depends upon, and that varies with device to device. So universally it is being given in the form of G. So G is the gravitational constant based on which the machine works. So it ranges from 500 to 700 G, and the minimum spinning time is 10 minutes. And the hard spin will be above from 800 and above for another 10 minutes. So in case we will be using this in order to convert, because my laboratory centrifuge will be different and my make will be different than yours. So that will not have the same radius. When you can consider the radius of the rotor from the middle to the tip of the tube, it will not be the same. So depending upon that, the formula will be, this formula can be used, where RCF is equal to, depending upon the radius and the gravitational constant, this will be varying, and the same can be used for conversion. If you are finding this as hard to produce, there are certain charts available where if you know the exact radius of the machine and you want the, you know, the G factor, then definitely it is going to go as this. And if you know the RPM also, you can just place it, place a line from the radius of the rotor intersecting the G factor, so that we'll be getting the value. So such kind of charts are also available, so, which makes our work simpler. And depending upon the kits that are available in the market, there are n number of kits available in the market, and I am just posting you one question. Right in front of you are two different sources of PRP collection kits. Which one will you prefer? Either it is on the left, that is BD vacuitainers, or the one INSYNC PRP method. So if you just chose based upon the company availability or the name which you are not familiar with, then here is what we are. Both are not suitable for clinical preparation of PRP, because it is clearly mentioned that it is IVD, it is for in vitro diagnostics, not for clinical application. Only you can just withdraw blood, analyze what is there in it, and then discard it. You cannot take it back to the patient. So in our practice, this should be noted that IVD devices should not be used for clinical application of PRP or for preparation of PRP. We'll be providing you the details about the kits available, and I just stated that based upon the rotors, there are two kind of centrifuges available. One is a fixed angle rotor, where the spinning capacity will be same as other, but the angle of rotation will be fixed. So the PRP preparation will be having a difficulty in this kind of tube spinning, and when it is a swing out rotor, the tube completely swings out, so that the PRP gets collected as a pellet. The RBC is removed as a pellet, and this is how the separation methodology tubes look like. So the separation part, if you are using a gel clot tube, then this clot will be there in order to separate RBC and your platelet, and this area will be having your PRP, which is not easy for recovery and application. So it is better to use a swing out rotor where the band formation of buffy coat will be clear, so that we can just take the first 2 ml and then discard the rest of the topmost platelet poor plasma region. Only the PRP region can be used for the final procedures. And in order to choose the tubes, there are many other if an option is given to you to use any anticoagulants, there are many options available: heparin, sodium citrate, calcium biotin. But clinically, which it is better to use acid citrate dextrose, that is ACD tubes, because that is clinically accepted for transfusion purposes, and activation of the platelet can be taken up easily after ACD blood collection. In case of EDTA blood tubes, EDTA forms a protective layer around the platelet, so that it does not allow the breakage or activation of platelets. So the growth factor quantity released from the EDTA tube is slightly lesser than that of that collected with the help of ACD tubes. So we have just gone through so many factors such as selection of centrifuge, selection of tubes, selection of anticoagulants to be used. If you have a general GLP setup, when you just line up all these parameters in an easier way, then it will be, we can just manufacture or produce platelet rich plasma at a very normal or easy way. And there are certain laboratory kits which is available with certifications. This is an 1 ml pipette, and we have sterile packed tips, so that which has an US FDA 21 CFR regulated certificates when we purchase it. So a single which costs only 4 rupees, and the tubes for collection is also single sterile packs. And for transfer, if you are not going to buy a pipette, micro pipette, then you can use a single sterile pack of Pasteur pipettes, which comes with again 21 CFR certifications. And if you just collect, buy a bag of ACD, which will be costing you around 340 rupees or 350 rupees. So we will be using it on a ratio of 1:8. That is 1 ml of ACD can collect up to 8 ml of whole blood. And as per this is the 21 CFR guidelines for PRP preparation as per US FDA. That is the main thing which we need to focus on. This is the PRP preparation has to be started within 4 hours of whole blood completion, and the final product should have a minimum standard of 2,50,000 platelets per microliter. And this PRP once prepared can be stored to 20 to 24 degrees Celsius, and has to be, no other preservatives has to be added. That is another parameter of the same. So this is the schematic representation of how a PRP is being collected. The main thing which we need to have in mind is drawing of blood has to be with an accepted anticoagulant, that is ACD. And ACD tubes after collection has to be tilted 5 to 10 times, so that the mixing of anticoagulants happen at a smoother rate. After first spin, measure the platelet count and even RBC counts if possible, if it is any contamination is available within the cells, either it is RBC mixed or not. And make sure that you always have the clear yellow fluid, and no hemolysis happens during the collection. So blood has to be collected as a single prick methodology. So first spin has to be at a RPM of 2000 for 10 minutes, and second spin will be having a 2200 RPM for another 10 minutes, and finally you'll be getting a pellet of Buffycoat, of which we'll be discarding the topmost half part, and then the rest of the part will be disturbed and then used for further application. So this is the parameter which we are following, and that has yielded with more amount of platelet numbers as well as. And next comes the activation part. So far we have prepared the PRP. Now we need to go with the activation. So collagen is a natural activator. In case of soft tissue, it activates at the site itself. But in case of external source, we can go with thrombin or calcium chloride. Make sure that you prepare a calcium chloride of clinical grade rather than laboratory grade. You can have purchase which has a concentration of 22.8 millimolar calcium chloride, or go for human thrombin, which is a bit costlier. So of which be careful that there are certain thrombin topic we can get it at a lower cost, but that is not for internal transfusion or internal application. It is for topical application. So kindly avoid such kind of activators. Or by mechanical trauma. Mechanical trauma is you can just make freeze and thaw the PRP once prepared. The final end product can be frozen and then brought back to room temperature. Either you can use an liquid nitrogen. If you have an embryological lab, it will be available over there. So the duration of freezing and thawing will be within seconds to minutes. But in case if you are going to go with minus 20 or 40 deep freezers, then the duration of activation by mechanical trauma will be still more higher. So the inflammatory response, okay, what will be the problems which we are going to face when it is going to be there with RBC or without with WBCs. When WBCs are present in more number, then if it's going to be a regenerative protocol, definitely it is going to give you certain delays and can cause muscle damage. Neutrophils can delay regenerative healing capacities. WBCs can suppress bone formation and bone healing, and more WBCs may be detrimental towards wound healing. So these are the major hindrance of WBCs. But in case of RBCs, more amount, once the RBC starts to lyse, then ROS will be produced more, and then it also helps, it also worsens the healing process. So far we have seen about preparation of PRP without any RBC or WBC contaminations from the same person. If the person is anemic, or if he is not able to donate blood, if he is on any blood thinners, then we can go for certain allogenic factors also, and that is also already in practice. So how come this becomes superior to that of your autologous? Preparation time will be ready, lesser, because it can be prepared already and stored. And if you allogenic can be of more larger volume, so either it can be collected from 50 ml to 100 ml of whole blood, and then can be processed, and multiple doses can also be arranged in case of allogenic. But in case of autologous, if vein puncture is done under tension, then activation starts during recovery of bleeding itself, as well as hemolysis will also happen during the collection time, and finally that will end up with bad quality of PRP. So as of now, we have just seen that we need to quantify the number of platelets that is being present in the PRP before and after preparation. But what will be the gold standard? That is because the quantity that is released by the platelet is not always equal to the quantity of the platelets. So there are many such articles available that total amount of PRP is not directly proportional to the amount of growth factors released by them, and it's not also proportional to the age factor also. So it's not only a number that we need to focus, but also the quantity of growth factors. So at least depending upon the indications which we are going to use. If it is going to be for wound healing, then definitely we can stick on with VEGF, which will be needed for angiogenesis, as well as PDGF, which is needed for muscle or fibroblast formation. So such kind of so in order to get more research data, we need to do a good quality PRP preparation first of all, and then focus on with the results and healing rate from the patients. So every lab has to standardize the RPM facility depending upon their machines first, and then mode of action, that is activation methodologies, has to be standardized, and then application part will take its own phase. Finally, to highlight on what allogenic PRP is going to do, either you can just purchase the blood bags, RH matched or ABO matched blood bags can be purchased from the blood banks, and the preparation methodology is also similar to that of your autologous PRP. Only thing we need to rule out is the infection parameters, and so far there are no obvious adverse events reported at many publications which we have seen through, and the major thing which we need to focus is the indications for which allogenic might be needed, and the major indications are platelet deficiency, anemia, long-term use of any antiplatelet drugs, and many more in the list. And from the labs of Plasmart, we are having an product off the shelf which is yet to be in the market, which has standardized quantity of growth factor measured, filter sterilized, and we have also added an photo inactivator method for pathogen reduction technologies for allogenic platelet rich plasma. So let us start to do PRP protocols in our regular day-to-day practice, so that we have more amount of data with us, and finally we'll end up with good results in regenerative medicine. Thank you.
Thank you, sir. Any other questions regarding the topic?
Hi.
Now the session is open for discussion.
Avinash
Audience can
Gandhi has
ask.
joined us. You can ask questions.
I request the participants to clarify the doubts.
Sir, a question. Sir, I have a question. May I ask?
Yeah, please.
Sir, are there any head-to-head comparisons of PRP with growth factor cytokine with regards to efficacy?
Sir, can you come again with your question, please?
Sir, are there any head-to-head comparisons of PRP with growth factor content sites, sir, for with regards to efficacy? That is GFC has the same efficacy as PRP or not, sir?
Sir, actually, I've just mentioned in my talk that GFCs are a part, the raw material for both are same. If it is going to be from platelet-rich plasma, GFC will be diluted in the entire plasma. In case of PRP, the 50% of the plasma will be rich in growth factor. So the proportion of or composition of the both GFC as well as PRP will be same. Only thing is the volume will be more. If you collect 10 ml of blood and prepare GFC, you will be getting 4 to 5 ml of GFC. But in case of PRP, it will be 2 to 2.5 ml of PRP. So you have a concentrated growth factor in PRP rather than having a distributed or diffused growth factor concentrate in entire plasma. So that is the difference between GFC and PRP. In both the case, if the raw material is blood, then both are going to have the same content, but the composition will vary and the volume will differ, sir.
Dr. Sarvajit, I want to add few things. Dr. Avinash, with the permission, I'm going to explain also. Sarvajit being a dermatologist, Sarvajit, like you are a dermatologist, right?
Yes, sir. Yes, sir.
Yeah. I understand why you're asking this because Workhorse company, they have got the DCG approval for the medical devices. They are marketing it as GFC. Am I correct?
Yes, sir. Workhorse is also marketing as GFC and certain other companies are also marketing as GFC, sir.
No, see, if you go and tell the company name again, because to my knowledge, Workhorse is the only company which is marketing GFC. There's one more company which is marketing as PRGF.
You can't recall the company name exactly, sir.
Yeah, because we did our search. We did our
Yes,
search.
sir.
Workhorse is the first company came with it. Maybe others they say, but it is not approved because or it is not even mentioned in the website. What they do is that they have the, as I told you, calcium chloride in that gel-based centrifuge tube. As Dr. Avinash said, no, the whole activated growth factors, it gets diluted in the plasma. So what we get is a diluted growth factor in the plasma.
Yes, sir.
You can pinpoint the amount of the more, if you want to have more concentration, you can go, because for dermatologists, as I told you initially only, they need a wider area for administration.
Yes, sir.
So I believe the head-to-head comparison is not actually possible. What you can see is per ml how much is growth factors. If you're going to see that, that can give you a good suggestion for considering the what way you can choose, whether it is superior, whether prefixed activator or self-activation or lysate.
Yes, sir.
But Avinash, if I'm correct, if you can add something to that for this question. Avinash, sir, you are there? You can add something.
Sir, if anything else.
I know, like you are amidst your guest lecture. So thanks for joining.
Yeah.
If there are any questions, I can take that on behalf of you.
Sure, sir.
Thank you for joining. Thank you.
Thank you, sir. Thank you.
So I have a few questions in the chat box. Shall I address those?
Yes, sir.
Yeah. So there is one question. PMS affiliates yes, PRP is also used for pain managements, and for sports injuries. So doctors can have interventions, and if you're comfortable in administration and if you're well versed with the protocols, it is also given for the PRP. Sorry, for the pain relief. And someone asked for the question for anemia. Dr. Ravi has given the answer, because anemia due to bone marrow depression, not exactly anemia, but due to the bone marrow depression, aplastic anemia cannot be treated. Thank you, sir. And next question. What are the job opportunities with MD with PhD? Again, this is a big question mark, because it all depends upon who's calling for what. Many pharma companies, they don't require PhD in regenerative medicine. They require clinical trial skills in case of regenerative medicine, because the trial design could be somewhat different. And for regenerative medicine, many times we don't require phase 1 trial. We combine phase 1 and 2, because there is no pharmacokinetics for this drug. I mean, there is no dose-specific pharmacokinetics, because so they combine both phase 1, phase 2, where they see both PK/PD as well as their safety. So with PhD, to my knowledge, you can be a good researcher. So that way, so that I can see. As far as rest, I don't have any answer for that. Is licensing required to do a stem cell for infertility patient in our center? Infertility. Okay, see, when you consider stem cell means it is, see, ICMR states something called as minimally manipulated, and it is more than minimally manipulated. In case of minimally manipulated, it doesn't have stem cells. It has PRP and it has bone marrow mononuclear cells, which can be prepared in a closed system. A company called as Harvest is having the machine. Why I mention the company is if you don't have research or if you got therapy, you can buy this machine, Harvest or Cipax or Arthrex Angel. Machines could be quite costlier, more than 10 lakhs, 25 lakhs and all. So these machines are completely sterile, where you can inject the bone marrow aspirate concentrate, and you can get a bone marrow mononuclear cells. After that, for passaging, that means what? For growing those mononuclear cells into a single lineage mesenchymal stem cells. Not single lineage, a single cell, a multipotent mesenchymal stem cells. You require a GMP approval. Yes, you require. And in Tamil Nadu, Stanley Medical College has got this GMP approval, and they're doing various research in that thing. And so regarding infertility, again, of course, licensing is required. You can have your own GMP lab. Few gynecologists or even having that. So this gives you an advantage of conducting research in case of stem cell. Dr. Sharath has P shot for female sexual dysfunction, sir. Like P shot again, PRP, same protocol in the preparation. So regarding efficacy, only gynecologists can say, because this is because there are no assessment parameters. What they go with is only the female sexual questionnaire, FSSI, female sexual satisfaction inquiry questionnaire. So that again could be due to various reasons, could be organic, could be psychogenic. So it is still evolving, sir. But people say, few gynecologists and few patients say, like, it is quite beneficial when there is dry vagina, and when they have poor orgasm due to the clitoral insufficiency, which is equivalent to erectile dysfunction, where because the clitoris is considered also kind of a glands kind of thing. So when there is poor blood flow to the area, and they feel poor orgasm also. And what are the existing limitations in PRP therapy that matters for the research? Yeah, the unmet need in the PRP research is standardization. How can we prepare a standardized PRP? That means standardized means not the preparation, which can be standardized for the efficacy, because there are many companies who says our system is our kit is standardized. No, because what found, there is high variability within the kits also. And many times when you go into the CDC website, you can only see the approval numbers and all. You will not see what exactly the kit contains and what are the safety. Nothing is given over there. So we have to assume that this is meant for PRP. And they give their own centrifugation time. Few say obviously only 10 minutes, and 10 minutes is sufficient. But there is no fixed proof of why somebody says 10 minutes, somebody says 12 minutes. again, for in that area, barring all that certificate thing, an adequate number of growth factors for each and every indication is required. For ED is different, for ulcer is different, for osteoarthritis is different, for thin endometrium is different, for alopecia or for any of the dermatological indication is different. So individual specialist, you have a pharmacologist should go to individual treatment specialist, ask the needs, and standardize the protocol with the research protocol. So with the research name, there is the ethics committee approval. Then you can address this unmet need where you can stabilize or standardize indication specific PRP, which is lacking all over the world. Because many times, even I have gone to Spain where they told PRP kits available. PRP kits can be quite costlier, and it can be a big brunt on the patient also. So with the standardized PRP, because IIDVL has given their own protocol, like there are many societies are coming forward to give their own protocol for the indications. Even orthopedic society or have their own protocol, so that you can discuss with that concerned specialist and get the insights. Then you can venture into PR research. So in IVF for proper implantation of embryo, I heard PRP is spread on the endometrium. Yeah, it is for IVF. They give for recurrent implantation failure for thin endometrium, and even they give for poor ovarian reserve. So it's all in the experimental stage, but it is working. Why I'm saying it is experimental means we cannot standardize it. It doesn't mean like it is not working. We can't standardize how many doses have to be given, and because it all depends upon that particular center protocol, and they when to optimize the hormones, when to give before the embryo transfer. So it is quite working. You can go and read about. I can tell you if researchers who are done good in the field, Dr. Naina Patel, Dr. Manjula Adakani, and Dr. Sunita Rilwakar. So these names you can search in the web and you can see the protocol and adopt whichever is suiting for you. So any site for PRP for testicular deficiency, again, is a very broad terminology. What you might be asking, sir, like how would it for the male infertility? Again, male infertility can be non-obstructive azoospermia, or for oligospermia. Of course, for obstructive azoospermia, so we don't give that. For NOA, if the patient is having NOA after OAT, that is oligo-acidoterospermia, PRP could be beneficial. In what way? To improve the number of counts, or improve the quality, or even post-vaccine also. Why? Because this patient, for oligospermia, that is for this patient, we can upgrade their fertility potential. Again, it is all in the experimental stages. What we may upgrade? If the patient is having a sperm count less than 5 million per ml, you can upgrade so that there can be a possibility of successful IUI. Or you can give a good quality sperms in the semen where single cycle IVF or ICSI can be successful, because the sperm, there could be poor quality sperms. So this kind of PRP can improve the sperm quality, thereby improving the outcome of the fertility management. And so that is for the testicular thing for male infertility. And in case of NOA, where there is a primary NOA, when there is no history of oligospermia and all, and we should never venture into that field. Why? Because there could be a Sertoli cell-only syndrome, there could be extensive, there could be even a Klinefelter syndrome, and these are the situations where none of the cell-based therapies can work, because there the regenerative potential of the testicular stem cell itself will be deficient. Because many times in the ophthalmology, they are finding that there is a stem cell deficient state, limbal stem cell deficiency, a trabecular stem cell deficiency. They are finding that a particular area, that particular deficiency, where you can go and inject stem cells, you can see the benefit. Whereas in case of male infertility, still, so people are being exploring that, and there are quite anecdotal evidences where regenerative medicine, where PRP or bone marrow or bone marrow cells are being beneficial, but on a larger scale, there is not much benefit. People can say, I can give PRP, I can give BMC to see whether I'll be able to aspirate the sperms during the microdose. Again, it's being experimental. So people can have their own protocol after getting the ethics committee approval. Is there any board that monitors adverse effect of stem cell for PRP? Again, see, when you tell about board, if you're going to see only about research, they have the ethics committee board, they have the IRBs. Of course, they are the ones who want to monitor. When it comes to stem cell therapy, stem cell therapy outside the approved indications, of course, again, your own ethics committee is required. Stem cell therapy within the indications, you are responsible for the adverse effects. Same for the PRP. Stem cell therapy for cones and rods. Yeah, you're asking about ophthalmology. Again, that is, I can share the recent lecture which we had last month, where a doctor from Dr. Muthukrishnan from Arun Eye Hospital gave a beautiful lecture on usage of PRP in case of ophthalmology. There he has given very indication specific and a protocol specific lecture. So because if I say this concept for cones and rods, I will not be the best person. Where he has given a good indication on where should you give, how should you give, how much should you give, and he spoke upon PRP. Yeah, Dr. Avi is also commenting there. Sir, I'll be sharing the link in the group, sir, for them. You can see that also.
So Dr. Farah Khan has a question for you. And due to technical issue, unfortunately, he is not able to join. So his question is, what are the pathways for a MD pharmacologist to pursue research in regenerative medicine in abroad, especially in nerve cell repair?
Pharmacologists to pursue research abroad, I think the pathway is all same, whichever the field you choose. But if you're going to do very specifically regenerative medicine, you need to show some kind of an work experience in case of regenerative medicine. Because once you go abroad, you are not going to treat the patient. You're going to be a lab-born researcher, maybe a PhD in India, or maybe some fellowship. So wherever they're offering. But again, you have to show some publications, and you are good in this neuro regeneration, which is quite challenging, and you will be impacted into that research segment. So that's all I can say. Maybe and she can ask more questions based on this.
Sir, can I speak?
Yeah, ma'am, please.
Good morning, sir. Sir, I want to know in India, what is the option, like with MD with PhD in pharmacology?
Yeah, ma'am. See, like as of now, I have not seen any calls for MD with PhD in pharmacology. If somebody wants to set up the regenerative medicine center, and if MD pharmacology is having that PhD degree, then it could be quite beneficial for them to show that they are good in their GMP skills, the research skills, very pertinent to regenerative medicine. Because regenerative medicine, I told you, it is cellular pharmacology.
So any there in Tamil Nadu or anywhere in Chennai, any like that research center is there?
You can visit once Stanley. They have a CGMP center.
Okay, sir.
So it'll be a good start for you to discuss with them. It's a government institute.
Okay, sir.
Mothers Regional Center, they're conducting fellowship courses in stem cell and regenerative medicine. It's an IMA supported certified course. It is starting from this year, and as of now, it is full. You can apply for next year in case if you're interested.
Which place, sir?
It's in Trichy. Mothers
Trichy. Okay, sir. Okay. Thank you, sir. Thank you.
Yeah. So I think we can close it off. If there are no more questions. Maniran sir. Okay, there is one more. MBA doctor is interested in stem therapy, choosing MD pharmacology better. Okay, that is again, it is a very difficult question for me to say, because you are choosing between two degrees, and it's up to you. I don't know why will somebody think of MD transient medicine after doing MD pharmacology? Not required just for stem cell therapy and all. Stem cell therapy is different. Stem cell research is different. Stem cell therapy can be done only by a therapist in that specific disease sector. Pharmacologists can do stem cell research in any field, and for research aspects, another degree is not required.
Thank you for discussing the answers for all the questions, sir. Thank you so much, sir. May I now request Dr. V. Sivashankari, Professor, Department of Pharmacology, to propose the vote of thanks.
Good morning, one and all. It's a privilege and a great joy for me to extend the vote of thanks for in this occasion. On the behalf of Department of Pharmacology, we thank our beloved Dean, Professor Dr. K. Elvindan, for the perfect guidance, motivation, and constant support rendered by him. Then I would like to record our sincere gratitude to our medical superintendent, Professor Dr. S.R. Rangabhashyam, for the enthusiastic support and guidance to carry out this program. I wish to say hearty thanks to our Deputy Dean, Professor Dr. Deepthi Shastri, for her constant encouragement, motivation, and guidance. We extend our sincere thanks to our beloved Director, Hospital Development Committee, Professor Dr. E.M.J. Karthikeyan, for his constant support and encouragement. On behalf of Department of Pharmacology, we extend a warm thanks to the guest speaker, Professor Dr. Natesh Prabhu, President, Indian Medical Pharmacologists Association, and Joint Secretary, Indian Stem Cell Therapy, for sharing his experiences on pharmacodynamics of regenerative medicine today. Thank you so much, sir, for the informative and interactive session. We extend our thanks to Dr. V. Ravi, MS Artho, Director, Mother Cell Degeneration Medicine, Maruti Hospital, Trichy, who delivered a wonderful talk on DCGI approved stem cell therapy. Thank you so much, sir, for the excellent presentation. We extend our thanks to Dr. Avinash Gandhi, MSc PhD, Chief Scientist, Mother Cell Regenerative Center, Trichy, who shared his experiences on PRP and bone marrow mononuclear cells preparation technique. Thank you so much, sir, for the wonderful session. We thank the Tamil Nadu Medical Council to appoint Professor Dr. Dandapal, sir, as an observer for this e-CME. Thank you, sir. An event like this e-webinar can't happen overnight. We are fortunate enough to be backed by a hardworking head of the Department of Pharmacology, Professor Dr. E. Manivannan, my colleagues, Professor Dr. S. Rajaram, Dr. R. Ramya, Dr. G. Karthikeyan, Dr. S. Swatika, Dr. J. Karthik Pandi, tutors, and all my postgraduates. I thank them for extending their willingness to undertake various responsibilities for making this event a grand success. I thank all the participants of this e-webinar from various medical colleges and also Vinayaga Missions Medical College and Hospital for showing their interest to participate in this program. Finally, I thank all subordinate workers, janitors who helped us in this occasion. Thank you all once again.
Thank you, ma'am. Now I'm going to end the session by thanking our Dean, Professor Dr. K. Elvindan, sir, and other WAB members to permit us to conduct this workshop. Once again, I thank everyone for their presence to make this program a grand success. Thank you so much.